I'm very, very excited to have our next panel speakers. These are all folks that actually work directly with our Anesthesia Patient Safety Foundation. All of them are directors in some capacity. So it is my ultimate pleasure to actually introduce them to you. So the first speaker is Emily Matankou. She's the chair of the Department of Anesthesiology at the Olive View UCLA Medical Center out in California. We appreciate you coming out just for this meeting and flying out tomorrow. It's not easy. Also the Director for Peri-Op Services with the Los Angeles Healthcare System, an Associate Professor of Clinical Anesthesiology at the medical school. She also serves as the Vice Chair on the ASA Committee on Patient Safety and Education, which is huge, and is very passionate about patient safety, and also serves as one of the directors on the Anesthesia Patient Safety Foundation. Her talk today is Neuro, which is very close to all of our hearts because sometimes we all actually dread going to these non-OR locations. I mean, what is it going to bring today? I really don't want to be down in CAT scan. I really don't want to go to MRI because it's down in the basement. So these are all these challenges that we face. And here is Emily to tell us how we can keep our patients safe in these environments that we really don't want to be in. And thank you so much, and please come up.
Good afternoon, everyone. It's really a pleasure and an honor to be here. Thank you, Dr. Sundar, for the invitation to the APSF. Today, I'm going to be talking to you about patient safety in non-operating room anesthetizing environments, which is becoming a significant portion of our practice. I know at my own institution, Neuro cases now comprise somewhere between 40 to 45% of our total anesthetic volume, and it's only increasing in the next couple of years. So it's really imperative that we do recognize the risks of Neuro and also figure out how to strategize how to care for these patients under very, very challenging circumstances. So in terms of my disclosures, I do want to mention, as Dr. Sundar mentioned, I am on the board of directors for APSF and the co-editor-in-chief of the APSF newsletter. I will be presenting some work from APSF at the end of this talk. So in this talk, we will be reviewing the evidence on patient safety in the non-operating room environment, describing some factors that contribute to adverse events in Neuro, and also reviewing some potential interventions that can mitigate patient harm in these areas. So this is a really good example of what we are talking about. I speak a lot on Neuro, and I put this picture on almost every single one of my talks because I think it's such a good example of the challenges that we face in this environment. So this is a cardiac cath lab that also has an MRI within it. So you can see here on the left-hand side are those big white wings. Those actually are parts of the MRI machine that swing in on those metal tracks to image the patient. Then you can also see the patient's head is where the table is, and then an X-ray on top of the head. You can also see the anesthesia machine that is shoved all the way in the back. And of course, this is an MRI-safe anesthesia machine, so it's not the anesthesia machine that we are commonly used to working with. And you also have this black line right here that is where the MRI-safe equipment can go and the MRI-safe equipment cannot go. What's not pictured on this image is that my medication dispensing cabinet, so my Pyxis, is completely opposite to the anesthesia machine. And my computer, where I'm supposed to be documenting my vital signs and doing my anesthesia record, is actually diagonal from the anesthesia machine. So in the course of caring for this patient, I could be walking across all four corners of the room, and if I'm drawing up medications or if I'm documenting something on the computer, my back could be turned to the patient, and the patient's already far away from all of these equipment. The head is also very far away. So if I'm doing a case under MAC in this environment, it can be very, very challenging to monitor their oxygenation and their ventilation. So it's very stressful to work in Neuro. It's very stressful to work in that cath lab. And this challenge is felt acutely by clinicians all the time in these Neuro locations. So there was a great letter to the editor from the British Journal of Anesthesia by one of my colleagues at Dartmouth, Dr. Hetty Schrock. She did interviews with clinicians about Neuro perspectives, and a few representative comments were that the mental work is much higher, and that's where the stress comes from. People operating in an environment that they're not 100% comfortable, I think, poses a risk to the patient in general. And having to be mindful of having every piece of equipment and every medication that one could foreseeably need requires a lot more preparation up front. So providing care in these areas we know is stressful. We've all felt that stress, but how does this actually relate to patient safety? So what's the actual evidence that Neuro locations are inherently more unsafe than the general OR? So just as a baseline, we need to know how much we're doing in Neuro. So this was the last good, large-scale, comprehensive epidemiologic study. It has data from the National Anesthesia Clinical Outcomes Registry from 2010 to 2014. So it's already outdated, but we actually don't have another study like it. What they found was that cases in Neuro increased from about 28.3% in 2010 to 35.9% in 2014. So 11 years later, Neuro cases are much more than that, right? The demand for anesthesia services in places like GI has increased exponentially. We are doing so much more in IR, in cath lab, with pulmonary embolizations, with TAVRs and MitraClips, that there has been such an exponential increase. So this number is already much higher, probably approaching somewhere close to 50%. So what are the characteristics of Neuro cases? They are much more likely to be started after 5 p.m. So 16.7% of Neuro cases were started between 5 p.m. and 7 a.m. compared to only 9.9% of general OR cases. They comprise an increasingly higher percentage of cases, and unfortunately, the patients do tend to be older and sicker and much more likely to undergo GI procedures. And all of these factors can contribute to adverse events in Neuro. So what does the evidence say about patient safety events in Neuro? And we can pull from two buckets of data. One is observed mortality data. So this is all comers of looking at patients coming to Neuro and looking at the observed mortality. And then we also have closed claims data. So this is data where there was such severe harm that occurred that a medical malpractice case was brought forward. So if you look at the observed mortality data, there was an analysis of greater than 47,000 pediatric cases. This was between 1998 to 2007, and found that the observed mortality in Neuro was twice that of the operating room. However, there was a much more recent retrospective study from some Korean authors that looked at nearly 200,000 cases from 2013 to 2017 that found that Neuro observed mortality was similar to that of the operating room. So again, these are all comers looking at all observed mortality. But when you look at the closed claims data, these are cases where severe harm occurred. There was an analysis from 1970 to 2001 that showed that claims of death were increased in Neuro, almost twice that of the general OR, and that was replicated in studies from 2006 to 2009 and 2000 to 2012. And in fact, more recent studies have also shown a connection between adverse events and Neuro. Their reports, adverse event reports, are higher in Neuro compared to the OR, so 31% compared to 6%, and severe adverse events are much more likely in Neuro compared to the operating room as well. Now, when you look at the closed claims data, compared to the general OR, closed claims from Neuro cases are more likely to be deemed to be due to substandard care. They're more likely to be thought to be preventable by better monitoring, and they're more commonly associated with problems with oxygenation and ventilation, which is not surprising given the amount of monitored anesthesia care we do in these areas. If you look at the number of cases, although GI comprises the vast majority of cases, at least according to NACOR data, cardiology and radiology cases comprise an outsized proportion of malpractice claims. And this may be due to the fact that there's less invasive procedures that are happening in GI, whereas if you are coming in for an IR procedure or a cath lab procedure, you are much more likely to be sick. One thing that I do want to mention here that we often speak of Neuro as kind of one thing, like as a monolith, but it's actually very different. All of the sites are different, with different patient populations, different levels of risk and comorbidities, different types of procedures. A patient who is coming in for a screening colonoscopy in the GI suite is very different from an 88-year-old with severe mitral regurgitation and pulmonary hypertension who's coming into the cath lab for a transcatheter repair of their mitral valve. So there are certain principles of safety and risk that exist amongst all the sites, but it's important to acknowledge that each of these sites have their own unique challenges. I'm going to focus for just a couple of minutes on the GI suite because it does comprise the highest percentage of anesthetic volume amongst all of the different Neuro sites. So, anesthesia services in the GI suite. This is kind of a controversial issue and became more controversial in 2017 when this paper came out. This was a non-randomized observational cohort study looking at over 1.3 million procedures. And it found that there was a higher risk of sedation-related events when anesthesia services were involved, with an odds ratio of 1.33. And they also did propensity score matching on these cases. So the cases where an anesthesiologist was involved and the cases where an anesthesiologist were not involved were pretty similar in terms of comorbidity. So this was controversial because there was an argument that maybe anesthesia services should not be involved in GI procedures. Maybe we bring some more risk and patient harm when we are involved. I do want to mention that there are significant limitations to this paper. There was a very wide definition of sedation-related adverse events, from the need for reversal agents, which can certainly be due to anesthesia, to perforation, need for conversion to open surgery, blood transfusion, which is all pretty much procedural-related complications. I think there is some argument to be made that when anesthesia services are involved in GI, the GI proceduralists may have the ability to be more aggressive, do a little bit more, and that may precipitate more adverse events. There were subsequent studies that showed that the risk was lower. This was a large study of 400,000 patients undergoing GI procedures. The overall complication rate was 1.09, with serious complications being only 0.34%. EGDs tended to have more serious complications as well as longer cases, ASA class 4 and 5 patients, general anesthesia cases, older patients, and overnight cases. This was an analysis of malpractice claims in the GI suite from 2007 to 2016. What was interesting here is that EGD cases comprised the largest percentage of cases that had a medical malpractice case, but only about 12.3% of cases were paid out, whereas ERCP cases comprised about 19% of the total number of cases, but about 53.1% of cases that were paid out. And this suggests that although EGDs in general may have had more complications just because of the sheer number of EGDs that we do, ERCP complications, when they occurred, resulted in more permanent disability or even death that required medical malpractice payment. This was another study. It was prospective and observational, looking at patient safety and adverse events. They found that patients who were ASA class 3 and 4, as well as patients with a higher BMI, were more likely to have adverse events. They also looked at cases divided by type of anesthesia and found that MAC was most commonly associated with hypoxia, whereas general anesthesia was most commonly associated with vasopressor use. So very logical. And that kind of brings us to the question that we are often faced in the GI suite is whether to do MAC or whether to do general anesthesia for these cases. And we often get a lot of pushback from our proceduralists one way or the other. We actually don't have a lot of studies on this. There's certainly room for more research to be done in this area. What we do have is a small study. This is of about 200 patients. It was a randomized controlled trial of ERCP patients undergoing general anesthesia or monitored anesthesia care. What they found was that MAC was associated with higher rates of sedation-related adverse events. It was 51.5% compared to 9.9%. And the other interesting thing was that there were no differences in procedure duration, success, recovery, or in-room time. So if the proceduralists tell you that MAC is faster because patients go to sleep faster, they wake up faster, turnover is faster, it may not necessarily be the case. Regardless, I think that anesthesia services continue to be needed in the GI suite. We do have evidence that when anesthesia is involved, the GI suite is more efficient. There are lower rates of procedure failure and sedation failure. The proceduralists are able to do what they need to do. There's decreased hospital days, improved throughput. There's also some degree of proceduralist satisfaction as well as patient satisfaction. And I think the American Society for Gastrointestinal Endoscopy agrees. They actually have guidelines for when anesthesia providers should be involved in endoscopy. They say whenever there are prolonged procedures requiring deep sedation, whenever there's anticipated intolerance to standard sedatives, when there's increased risks for adverse events because of severe comorbidity, or when there's an increased risk for airway obstruction. And I would argue probably the vast majority of our GI patients fall somewhere in this category. So we will continue to need to be involved. So the complications in GI occur, but they also occur in Neuro in general. So the question is, why are we seeing these adverse events, and why is it perceived to be so much more stressful to work in Neuro compared to the general OR? So let's talk about a few risk factors. One is that these patients that are coming to these areas may not necessarily be open surgical candidates, but they are candidates for more minimally invasive procedures. So think back on that 88-year-old patient who has severe mitral regurg, pulmonary hypertension, needs a mitral valve repair. That patient is a terrible candidate for open heart surgery with cardiopulmonary bypass, right? But is a pretty good candidate for a MitraClip and can have significant palliation of their symptoms if they get that MitraClip. We are also constantly pushing the envelope with regards to what is being done in these areas. Interventional pulmonology, they're now doing tumor debulking and endobronchial stents. Interventional GI, they're doing per-oral endoscopic myotomies, which basically amounts to surgery. So we are pushing the boundaries with what is being done in these areas. And what's often thought to be minimally invasive may not necessarily be so. MAC is a common anesthetic modality and may be a factor in contributing to these problems with oxygenation and ventilation, as we've seen with the closed claims data. So one way to start thinking about how to improve care in Neuro is to identify what some of the root causes of adverse events are. One is location. The Neuro location may be physically located far away from the main OR. Dr. Sundar mentioned one of the locations being in the basement. I visited institutions where their Neuro location was in a completely separate building. So that makes it very difficult to access additional personnel, additional equipment in the case of an emergency. Many of these areas were also constructed decades ago, right? Before anesthesia services were so heavily involved in the care of patients. So it's really difficult to retrofit everything that we need to provide anesthesia safely in these areas. The ergonomics can make it very difficult. Often the space that is allocated to anesthesia is very small, and you may not have access to everything that you need, whether it's equipment, scavenging, pipeline oxygen. I know at my own institution, we had to purchase a smaller profile anesthesia machine that was able to fit into the cardiac cath lab because our regular machine wasn't able to fit in there, and the cardiac cath lab is very, very old. The team. So the team may not necessarily be used to working with patients under general anesthesia. They're often used to working with patients under conscious sedation. They're used to kind of directing what sedatives to give and how the sedation should go. They may not be attuned to what the concerns of the anesthesia team are. And on our side, we're not necessarily familiar with all of the procedural risks or the procedure-specific steps that we should be paying more attention to. All of this creates a lot of distraction, right? So figuring out where the machine can go, how to monitor the patient, whether my anesthesia circuit is going to survive going into the CT scanner, it creates a lot of distraction that really takes away from caring for and monitoring the patient. And finally, there's a lot of production pressure. These cases are often short with high turnover. There's a lot of pressure to get in and out quickly, and that potentially could lead to taking shortcuts that can compromise care for our patients. And all of that increases the cognitive burden in Neuro. This is another study from Dr. Schreck. It's a qualitative study looking at clinician perceptions of safety in Neuro compared to the OR, and across the board, perceptions of safety in Neuro were much lower. There was higher anxiety, higher mental load, higher temporal load, effort, and frustration in Neuro compared to the OR. So regardless, there's a lot that we could be doing to improve safety in these areas. One thing that I would like to highlight that there are many systematic design problems in these areas that are not easily modifiable. Unless you are able to do new construction on your GI suite or your cath lab, you're going to have to work with what you already have. But there are factors such as patient preparation, communication, teamwork, collaboration that are much more easily addressed and can also have significant improvements in patient safety. So a couple of things. One is that we have to do good patient preparation. So patients have to be optimized and prepared the same way that they are for the general OR. These procedures are short. The drive to be efficient can lead us to want to cut corners or take shortcuts, but that's not in the best service of our patients. And especially these patients are a lot older, they're a lot sicker, they may need a lot more preparation and optimization up front. We also have to make sure that we have the same standards for monitoring that we do in these non-OR environments as we do in the general OR. And finally, we have to be prepared for monitored anesthesia care. I know I spoke about how it may be more risky, but in many cases, our only choice is to do MAC. So we have to make sure that we are prepared for problems with oxygenation and ventilation, and also for instances where we may have to share the airway with the proceduralists. Some things that can help are adjunct airway devices. There are many that are on the market that can really assist if you are providing monitored anesthesia care. One is nasal CPAP. There are several types on the market. These can deliver positive pressure ventilation to stent open the upper airway, allowing better oxygenation. High-flow nasal cannula has a very similar concept, prevents atelectasis, improves oxygenation and ventilation. I actually purchased high-flow nasal cannula for my department and actually stationed one in each GI suite and in each IR and in each cath lab. So that has been pretty helpful. And then procedural oxygen mask does provide more oxygen than a nasal cannula while allowing access for the endoscopist as well. So some other ways that we can help mitigate risk. I think the key thing here is that we have to improve situational awareness for all parties involved. So we have to make sure that we do good preoperative optimization, as I mentioned, safety huddles for patients that may be at high risk. We should forward patients that may be of concern to our pre-anesthesia clinics well ahead of time. Standardizing care through pathways and protocols allows for a shared mental model for procedure-specific steps and needs, so allows better teamwork in the end. Having an established liaison between anesthesia and procedural services. So this allows someone to handle the daily quality and safety issues that pop up. So a director of Neuro, for example. We also want to make sure we have interdisciplinary conferences with our proceduralists, our nurses, our anesthesia team, technicians, to review previous cases that could have gone better and upcoming cases where patient comorbidity is a concern. Having a smaller, dedicated team that works together often in Neuro can also improve team familiarity and patient outcomes. We know from the general OR literature that surgeon anesthesiologist teams who work together frequently have patients who do much better. So that can be applied to Neuro as well. So improving team familiarity by also having shared spaces where people can work or socialize can also help with that as well. And finally, doing team training and in situ simulations in the area where the cases are supposed to happen can help identify pain points, not just for the procedure, but also for each of the different teams involved. So in 2022, the Anesthesia Patient Safety Foundation convened a conference to create consensus recommendations on how to conduct care in these areas safely. There are 42 recommendations in total, so I don't have the time to read through all of them, but a few highlights include that anesthesia personnel should participate in the construction and renovation of Neuro locations when applicable, that there should be emergency equipment available to treat both malignant hyperthermia and local anesthetic toxicity, that communication, team building, and training should be established in a multidisciplinary fashion, that there should be good pre-procedural evaluation and optimization, that intra-procedure care and monitoring should adhere to ASA standards for basic monitoring, that there should be a post-procedure care area, and that continuous quality improvement occurs in these areas. If you look through the recommendations, I think there is an overall theme that robust communication really is essential to maintaining patient safety in these areas. So there is a definite real risk of patient harm in Neuro. There are a lot of things that we can do. We can try to optimize ergonomics and location, do team building and training, optimize our patients, and also have directed leadership and participation at regular conferences.